We welcome you all to the masterclass Scale Advanced ART Masterclass series. So, as you all know, we have both embryology and advanced ART masterclass, and currently we are having one advanced ART and one embryology masterclass every month. So, just to briefly give you, we've covered topics like fertilization, implantation, and oocyte quality, and about IVF and ICSI. And we've had an advanced AST masterclass by Sanjeev Reddy sir on RIF and by Sachin Kulkarni sir on endocrinology and stimulated cycles. And also we've had Sarguna Devi ma'am speak about embryo quality assessment. And our next masterclass in embryology will be on the 19th of June by Dr. Kirsi Avari. It is going to be about cryopreservation. And the next advanced ART class will be by Dr. Sachin sir, probably in the month of July. So I request Vasundara ma'am to introduce our esteemed speaker for today.
A warm welcome to one and all. It is indeed a proud privilege and a great honor to introduce such a mentor and a great teacher amongst all of us. And I profusely thank Raju sir for being a mentor for the Scale platform. Sir is the Emeritus Professor of Human Genetics in Andhra University. He is the Honorary Professor of Department of Biotechnology in Andhra University, Adjunct Professor at Ramachandra Medical College and University, Program Director of Recognized Research Center again in Andhra University, former visiting professor at the Department of OBGYN, University of Graz in Germany, Samsung Research Institute. He was the winner of the Best Channel Partner Award 2019, member of Board of Studies, Department of Human Genetics from Andhra University, member of Board of Studies, Journalism and Mass Communication, member of Board of Studies, Department of Biotechnology from Andhra University again, and he's a PhD from Gitam University, and lots and lots of more achievements which cannot fit into one slide. And sir has got lots of lifetime achievement awards also to his credit. And today's topic is going to be on decoding of receptor polymorphisms. I think no other person can do better justice on receptor polymorphism because sir has done extensive research and doing routinely receptor polymorphism in his own center in VIZAG. And most of us have collaborated with him for this study for our patients to give better outcomes in the cycle. So receptor polymorphism, as we were discussing with sir, we've got a lot of science to it, and whether FSH, LH, E2 receptor polymorphism is the only thing, or they have any interconnection amongst themselves, and based on the receptor polymorphism, how we are going to individualize our stimulation protocols in the next cycle to give optimal outcome. So this is going to be in two parts. Today, sir is going to take the first part in the polymorphism topic. And without much taking time, I would like to ask sir to please take over the session so that we have much interaction later on. And at the end of 30 minutes, we will have few poll questions based on sir's discussion. And in the end of the session, all of us can have a Q&A with sir. Over to you, sir.
Yeah. Thank you, Vasundara. Thank you, Sindhuja, for giving me the opportunity.
Request all the delegates to keep the video also on so that there is a biofeedback for the speakers in this webinar, and we would want it to be more informative and interactive.
There is an evolving concept in ovulation induction. For a long time, we are only aware of absence of FSH and LH action or excess of FSH LH action. But there is a third concept coming called deficiency of action. And this was introduced in 2017 by the International Committee of Monitoring of Assisted Reproductive Technology, ICMAT. So when you look at a patient, are we looking at absence of FSH, LH action, excess of either FSH or LH. The third component is deficiency of action. We have never been taught about this concept, even though it is existent for more than 8 years. So this concept, when we put it on the follicular development, we only speak about FSH threshold or the gate concept, but we never look at the role of LH, and also we never look at hypofunction of the follicular development. In a natural menstrual cycle, things go perfectly well, but we should make a major difference when we're doing a stimulation. Are we doing an anovulation or are we doing a control ovarian stimulation? Anovulation is a disease state wherein there's a failure of ovulation and you're correcting it. And the goal there is to develop a single or a few follicles. While in control ovarian stimulation, large numbers are generally preferred. This concept has been repeatedly emphasized, and even in the volume 8 of Human Reproduction Update, Filcori, who did a lot of work on LH, has explained this concept. In a single follicular development, you're gently correcting the failure. In a control ovarian stimulation, you're breaking the regulation to produce massive number of follicles. So that concept, when we start the stimulation, should be in our mind. Are we disrupting the induction of ovulatory process, or are we gently correcting it? And then apply that concept in individual ovulation induction, and also in IVF, the PCO and the non-PCO group. In the PCO group, there is a basic failure of mechanism, so that unless you're careful, your disruption might be excessive or under, and you end up with a bad state. Whereas in a control ovarian stimulation, you're destroying a perfect monofollicular development and producing multifollicular development. That is a key concept we should keep always in mind. So I would prefer to, when I start my stimulation, to look at my AFC count, to correlate my AMH levels, to look at the facial profile, whether there are signs of androgen excess, and the body hair pattern. Because one of the biggest problem we have is testosterone measurement. Testosterone measurement should be measured only by mass spectroscopy. But because of the limitations and availability of mass spectroscopy, all of us do it on the conventional ELISA or chemiluminescence method, and that has a lot of error. You can't take that at face value because it is not a perfect value. You should also use your clinical science to look at the facial profile, whether there are acne, to look at the under the chin, whether there are signs of hair pattern, or where the signs of hair removal where you find dots. And when you're doing a TVS, look at the thigh whether there is any hair pattern. These are subtle signs which will tell you an androgen excess, even though they're camouflaged for personal body image purpose. And then count the number of follicles and then do your stimulation protocol. Unless you start with that, then otherwise you end up doing excessive number of eggs or less number of eggs. So if you look at two-cell 2-gonadotropin concept, this has never really changed. Only it has evolved over a period of time. Initially, we did not have this LH receptor images on the two-cell 2-gonadotropin therapy. We had the early follicular phase and the mid follicular phase. Then we realized that LH receptors appear on the theca cells right from the beginning, but on the granular cells, LH receptor appears. Initially, it was thought they were coming on the 8th day of the cycle or 9th day. Later, it was thought on the 5th day. Now it is being realized these LH receptors start coming in as early as 5th day of the cycle. So when you're giving the medication, your receptor action on the theca cell is right from the beginning. On the granular cell is from the midpoint, and FSHR is throughout this section. So once we remember this concept, then you go to the hypothalamo pituitary axis, where apart from your basic mechanisms, your thyroid status can disturb it, your prolactin status can disturb it, your nutrition status can disturb it. A woman smoking can disturb the feedback mechanisms. We never look into that. And also, your antifungal drugs can also disturb the estrogen production and in turn the feedback mechanism. And we never look at it. We just look at that it did not respond. So the reduced FSH LH action implications are any of these things, and you should have a checklist of seeing whether these are there or not before you start a cycle. The LH deficiency can be reduced production, which can be congenital, which can be acquired. Like I said, if they are acquired, anorexia, excessive exercise of high intensity exercise can also change the JNR pulse frequency, eating disorders, age-related DNR pulse. Then when it comes to the tumors, and then iatrogenic. All these produce an FSH and LH deficiency, which can reduce your developmental problem. But when we give a medication, we are only thinking about the ovary and it is failing to respond, but not looking at the whole environment. This is a key information we should start looking at when we do a stimulation protocol. When we do a stimulation protocol, when we do a starting dosage, we just say give 200 dose or 250 dosage, but think back why you're giving that dosage and why can't you reduce it or increase it. If you ask yourself in the mind that question, then the whole history should flash back about the hypothalamo-pituitary axis and its interaction in that given environment. Then in the antral follicles, this is the FSHR receptor. This is the LH receptor. This orange is the FSH molecule. Then the LH. So if a lot of people give two different molecules of FSH, that is, they give a urinary preparation and a recombinant preparation. Even though they're identical actions, the chains are not exactly similar. So in that context, when you have a receptor, when it gets that molecule gets attached to the receptor, in the initial phase, it's the proliferative action and anti-apoptotic signals. In the 4th or the 5th day of the cycle, it is both steroid proliferation and anti-apoptotic. And from the 6th day, the LH starts acting and the ovarian signaling acts. So if you're giving HCG instead of LH, a different action can occur. If you're giving a combination of a recombinant FSH and a urinary product, even though they're marked as FSH, they're not exactly the same molecules. We generally try to mix them and give them a lot of people. And if you look at this slide, that means the receptors are occupied in different ways, and the pathway will have a negative consequence. In a young patient with plenty of follicles, whichever thing you give, that is compensated. But when there is a suboptimal response, a poor response, then giving different drugs may not produce optimal action, because here the way they're attaching, and this is a beautiful article which everybody should read, which was published in 2021 in the Human Reproduction. It's a fantastic article. Unless if somebody is planning to use receptors, they should read this article because it gives a fundamental concept. Then when you're looking at a control variant stimulation, we're having a poor responder, a super responder, and a hyper responder. We never define what is poor responder instead of so many years. IVF is 40 years old or 45 years old. Still, we are struggling with the consensus statement of a poor responder. And hyper responder, we never gave any importance, even though it is 40 years old. And in the super responder, we are confusing between at risk for hyperstimulation and a good responder. We are worried when the E2 levels reach 3000 with good follicles and no small follicles compared to an excessive response patient. If you look at the doubling times, the doubling times are different in a good responder and in a patient at risk for hyperstimulation. Because in a hyperstimulation patient, you see a large cohort of small follicles or medium-sized follicles in addition to the dominant follicles. Whereas in a good responder, you see all the follicles being responding well, and that is where you try to tinker it and spoil the situation. Did you ever do a study with your own patients when all the follicles are good sizes and there were no small follicles and you got E2 levels closer to 3000? Did you ever get an early hyperstimulation? I'm not speaking about late hyperstimulation. Look back into your records. Did you ever get a early hyperstimulation? Seldom you will get early hyperstimulation. Maybe the mechanisms for late hyperstimulation are unknown as on today. Why somebody gets late hyperstimulation with the same number of corpus luteum, why somebody does not get it is still unknown. But I'm speaking with early hyperstimulation. If you go back to your records, look at the good follicular development, go back to the scan images. There are no small follicles. Did you ever get a hyperstimulation? If you did not get it, why are you tinkering that patient? Then, are we giving a starting dosage based on the criteria? Age alters the response. Number of AFC with androgen excess alters the response. A high AMH alters the response. And here are we titrating the dosage based on the starting dosage? And if not, we better do that. I have one more question. In an antagonistic cycle, once you start the antagonist, how much of fall of FSH happens, provided you don't alter the dose and you're continuing the same dosage. I want the audience to respond. Suppose you're giving 250 units in an antagon protocol. Then there is an endogenous protection also. And then you start giving antagonist. How much of a dosage does the ovary has lesser amount of availability of dosage after you start antagon? First of all, am I clear in my question?
So your question is whether we need to alter the dosage of...
No. How much does it fall? What is the rate of production of FSH in a given woman?
Dr. Sudha Jyoti says 75
That's her opinion.
international
The
units.
units, 75 milliunits per ml, per dl, per liter, per body, or per kg.
75.
75 is fine. Is it per ml, per dl, or per kg body weight, or per human being? Then, if you are giving them early, then what happens to the receptor occupancy rate? We never think about it. As the follicle becomes dominant, the sensitivity increases. But there is an intermediate group of follicle in moderate responses which need dosage. And if we decrease the availability of FSH, are we harming the cycle? Why are we speakers not speaking about that concept? And that's a point to ponder, because you're reducing the dosage at a time when some of them might be in the intermediate range. Some people might go for the fixed protocol of 6th day. And in that, sometimes if the size of the follicle at the beginning day is 4 millimeters, then by 6th day there will be only 11 or 12 millimeters in size. Then they add antagon. That means they're reducing the available dose of FSH to the follicles. Then they say it is not responding. Why do we never think about that concept? There, sometimes we blame the receptors, not realizing we have not understood the physiology of antagon and gave it too early and reduced the available FSH. A poor responder is a patient where you have 5 follicles, you should get only 5 follicles. Whereas in a hyperresponder, you have many follicles, but you fail to get good number of follicles. It can be the gynecologist itself, the product itself, or the human body. All three can play a role. And if a hyperresponder is given adequate dose of FSH, then the role of LH comes in. This is where the granular cell and the theca cell both having LH receptors happen. That is around the 6th or 7th day. That's the reason by addition of LH, your follicle output ratio changes. So the evolution of concept is a poor responder, a hyperresponder, and a Poseidon concept. But what is being missed is a deficiency of action, which has been introduced into the concept of ICMAT. And Poseidon 1 and 2 can be also labeled as a deficiency of FSH-LH action. Unless you think in that way, then your stimulation protocol and the receptor understanding will end up being too confusing. And in 2011, we had a consensus statement with the PC Wang. PC Wang also happens one of the co-author who did the first gift with Richard Ash. PC Wang from Singapore was the co-author of the gift procedure in the 1990s or much earlier, 1980s, I think, when gamete interfallopian transfer was done. Richard Ash and PC Wang were the co-authors. PC Wang heads the Singapore National University team. Now he's an emeritus professor there. And much before the Delphi concept, the Poseidon concept or the poor responder Bologna criteria, he proposed this concept where a poor responder are defined as oocytes less than 4, then role of age, then he has defined that anybody who has adequate number of oocytes with adequate FSH dosage, add LH, will alter the response. That was in almost 2011. So the current predictors which we use are age, FSH, AMH, AFC, ONML. But the problem is we have too many protocols. And during the last 40 years, the monitoring of the follicle did not change. The E2 and the ultrasound have remained the only markers for us to look at the cycle and define them as poor and driven response. In 2012, we started our work on initially on the LH gene, and then the human chorionic gonadotrophin receptor, LH-CGR, FSH, then realized that more LH and FSH genes produce more of complete reproductive failure rather than infertility. Then we moved to the receptor as a polymorphism. Then started doing the receptors for every patient from 2014. And from 2015, we started managing all patients only by polymorphism basis. And this we published in 2018. But I'll tell you the basic concepts. Initially, we studied the 3 receptors of LH. This is how the change looks like. This is a Sanger sequencer, and then we have the next generation sequencer. And the key findings of our study was there was a need for LH supplementation at 312 G by G and A by G, where in G by G, arginine and serine replacement happens. So the conclusions of this were homozygous for G alleles require LH. Heterozygous were more likely to require LH. But the concepts are as follows. So if you look at here in a glycoprotein, G protein, you have 3 components. The extracellular component, the transmembrane component, and the internal searing play a crucial role. The extracellular, called the hinge region, has different receptors for different molecules. The place where HCG attaches and the LH attaches on this receptor is slightly different, and these eight motifs have different actions based on the other receptors and other genes, and the internal ring activates different components. If an LH is added, then if LH is added to the hinge region, the cyclical AMP is activated, and then the androgen production is activated. In turn, the second group of messengers get activated, and the follicular growth happens. This is disturbed in heterozygous and in homozygous. So essentially, in receptor polymorphism, the attachment of the LH molecule to the hinge region and the efficiency with which it stimulates the cyclical AMP determines the response. So when this receptors are, when attachment is not perfect, you are giving it again so that LH supplementation acts. So in a G by G situation where LH is needed, there is an impaired signaling which leads to less cyclical AMP and androgen production. And by giving LH supplementation, this is corrected. So the LH acts at the G protein receptors. Then in turn, this hinge region, this is the purple line, which is within the cytoplasm of the granular cell. And produces corrects the signaling and then improves the follicular development. So this can be considered as deficiency of action of LH. So when you give a supplementation in a patient with A by G and G by G, the responses become equal. Whereas if there is a deficiency here and it's not given, then the responses do not occur. The concept of pharmacogenomics is if you have LHCGR 312 A by A, there is no need for any LH action, and the response is perfect. If you have a heterozygous, by adding touchdown units, you're getting a response. And when you have LHCGR 312, there's a suboptimal response or also the hyperresponse, and that is where you give 75 units. This can be known by two methods. One is you can do the LH polymorphism and start LH right from the beginning, or if you do not have a facility for a receptor polymorphism, you can also find suboptimal action of LH by the following criteria. With adequate number of follicles, with adequate dose of starting dosage of FSH, and the follicles are visible on the ultrasound, but your E2 levels are not growing at the desired rate, or the rate of follicular growth, which should happen between 0.9 to 1.6 per day, is not happening by the 6th day. There, instead of increasing the dose of FSH, add LH supplementation. That is how you can manage without doing the receptor polymorphism. The whole it works equally efficiently. So I'm repeating it. You don't have to have LH polymorphism for every patient. If you are using only pure FSH and given adequate dose of FSH based on the age, body mass index, thyroid antibodies, the health issues are present of collagen disorders, the presence and absence of endometriosis, and a given adequate dose of FSH, and the rate of growth of follicle by 6th day is less than optimum, and the rate of V2 levels is less than optimum, there, instead of FSH increase, add LH75 units. That will solve the problem. You don't have to have LH receptor polymorphism for every patient. But here I am repeatedly emphasizing, provided you have given only pure FSH as a stimulation protocol. If you are given HCG, there is no role for LH supplementation in those patients. This is an important document that is there in the Frontiers in Endocrinology. One can download it. It's an open source article. And here, this was published by all of us in 2021. The consensus statement, how to use FSH. And in all these persons, the most prolific work was done by Manuel Simoni. She was working on receptors right from 2000. Any paper which has her name, read that paper to have a better understanding of gonadotropins and also the receptors. She is supposed to be one of the top endocrinologists in the world as on today. When it comes to FSH receptors, there is a lot of confusion because too many papers have come in and too many small studies have come in. Some studies as less as 20 patients have come in with an opinion. You can divide them into 307, 680 and 29. RS616 and RS6165 are 307 and 680. They're always constant. That's called they're in the equilibrium. You don't find different types of. So if you have 307 A by A, you'll find 680 A by A. So remember that. And this is the FSHR 29. The importance of FSHR 29 is this is at the promoter region and this is at a different region. So the effects of this and this are different. So if you look at FSHR 680, A by A, A by A produces more number of follicles compared to G by G. That is the preliminary estimation. But when you're looking at FSHR 29, here A by G has a different action. Now, why I divided this lecture into two components is in the LH-CGR, the concepts are clearer. If you have suboptimal response with adequate dosage, adequate number of follicles, just adding 75 units is adequate. Or if you have a polymorphism, if you have A by G, add 37. If you have G by G, add 75 units right from the beginning, be it agonistic or antagonistic protocol. But in FSHR, you have to look into three groups. FSHR polymorphism in poor responder patient, FSHR polymorphism in polycystic ovary, FSHR patients in good responder in a non-polycystic patients. The dosages vary, which I'm going to speak in the next lecture. Now I'm open for questions.
Thank you so much, sir. Actually, was a complete of the open the chapter is going to be extremely difficult for us to comprehend. Your summarization, taught us a lot of interesting chapter today, and we will be having few poll questions based on what you have taught now. So, while Sindhu is posting those questions, I would want to, take few questions from the audience. So, one question is in PCOS we have different phenotypes, no sir. So, do you recommend that, before starting stimulation, should we do polymorphism testing in all PCO patients?
The answer is no. In a PCO patient, look at the Hirschism score, then look at the AMH levels. And if you have the mass spectroscopy, look at the testosterone levels. Then the pattern becomes very, very clear. And the one with the hirsutism, with the androgen excess, with the classic PCO pattern, there you find your AMH is closer to 10. That is more important. And there we started just doing the review of literature to look at the role of AMH receptors in that group. And in that patients, the practice I do is I look at the number of follicles, I look at the hirsutism score, then I look at the size of the follicles apart from the number, and then also look at the AMH levels. Then if you divide them, they fall into different groups of very clear pattern. That is what we are missing to do.
So in these PCO patients, sometimes, because of their elevated androgen levels or very high AMH levels, our dosing itself can vary because of fear of hypostimulation. They can also hypo-respond if our dosing is not correct. Isn't it, sir? Sometimes we get very resistant to stimulation in certain group of PCO patients.
There, the protocol is look at whether there is an adrenal component there. Look at for the 17-hydroxyprogesterone levels.
Yes, sir.
How often we do in a PCO patient with high AMH, an adrenal factor to be ruled out. We never do that.
Okay. One of the very points that you have mentioned to all of us. Yes.
Then second thing is, if there's an adrenal component, then that's where the role of an endocrinologist evaluation comes in, mainly for the medical legal reasons rather than the necessity. And there the role of dexamethasone comes in. And then after the dexamethasone therapy of 6 to 8 weeks, if you look at the ovary, the distribution of the follicle changes. That's one thing. The second thing is the one which does not have excess adrenal component. There, the role of AMH, role of metformin in reducing the testosterone and AMH plays a major role. We never try to reduce the number of follicles because metformin is known to reduce AMH and also the testosterone. You're correcting the underlying problem and then do the simulation, be it antagon or agonistic, it works for both of them.
Yes, sir. There's one question. If we use recombinant FSH and HCG since beginning of stimulation, will it be helpful in LH receptor polymorphism patients?
The answer is technically no, because your premature progesterone gets elevated. because when you look at the whole concept of when LH, there's an interesting article in Human Reproduction Review almost in 2012 or so, which is even relevant today. One receptor, two gonadotropins. That's the name of the article, I think, where the same receptor, when it attaches to that, what is the downstream effects the article gives it. If you give HCG there in a PCO, in a patient, your HCG is designed to produce massive amounts of progesterone. So there your premature progesterone elevation can become a factor. Now with the withdrawal of pure LH, it was withdrawn not because of scientific reasons, it was withdrawn because of marketing reasons. There you can use 75 units of pergoveris where it will give you 37 units of LH. Or if you want to have 150 units, then 75 units of LH, then use along with Gonalev 1 ampule of pergoveris, which will be sufficient. Because the costing is different between Gonalev and pergoveris, even though the molecules are same. If you go back and look at it, the cost of 150 units of Gonalev plus 75 units of LH is more than 1 ampule of pergoveris. Technically, it should not be so. And in Germany, the cost is reverse. If it is universally the same cost, it's fine for me. In Germany, they never introduced LH molecule. So that's the reason most of the work that comes from Germany comes with pergoveris. LH was never introduced in the German market. They are more than science in the publications, because you have to look at it whether the country has that molecule. All German publications, you never find an LH article published because it was never introduced in that market.
Quite interesting to know, sir. So, in your practice, do you do a fixed antagonist protocol or do you do flexible? Because sometimes what happens is we do measure the LH levels, and LH levels are very low despite the follicles keeping HMG from the beginning. Even on the day 7 days, the LH levels are quite low. So, do you use flexible antagonist or fixed antagonist? What do you recommend in which patients do you go about?
Our criteria to use an antagon protocol is AMH more than 5, AFC more than 30 is the criteria to do an antagon protocol. If it is less than that, I prefer the long protocol. If it's more than that, I prefer to use the antagon protocol. And in the antagon protocol, I don't measure any hormones. But I see that I tell them what is first day to the patient. It is an arbitrary, but I define my first day. I say that if your cycle comes before 6 o'clock in the evening, consider that as a first day and start stimulating the second day. If it comes after 6 o'clock, consider that day as 0 day, and then the subsequent day as the second day. We are fixing that. Second thing is, in an antagon protocol, we never adjust the egg pickup day to so that we avoid weekends. We don't do that. We don't manipulate the cycle for the weekends. So that way, what happens is your number of what we realize is your number of premature or excessive oocytes are avoided to 10% of the situation. If you pull the cycle or push the cycle, then your number of prematures are also changing. Then we use the Peter-Humayden concept of fresh cycle based on the number of oocytes we obtain and the E2 levels, and then add HCG 1500 units if it fulfills the criteria of the Peter-Humayden concept.
Okay, sir. So you were mentioning about premature progesterone elevation, but in the follicular phase, when we add recombinant FSH, it's quite understandable that there is premature progesterone elevation. How can you explain HCG causing premature progesterone elevation? Sir?
No. Actually, what happens is, if you look at it, the action of in the animal experimentation or in the cell cultures, where they put the Tika and the granular cells, also measuring the receptors by histopathology and immunohistochemistry, receptor density, then studied the additional LH and looked at the culture media. That work was done by Simone. There are a lot of classic papers are there because she was doing that work right from 2000. And she was, and all these people, all the major people, whomever who is speaking today on gonadotropins, have worked under her or did their residencies or their PhDs under her, at least 80%. And her articles are goldmine. Your clarity of concept comes very, very clearly. I think I'll share a couple of articles privately to you, then you can redistribute because technically I am not supposed to share.
Sure.
But
And,
I'll share it to you so that you can share it because I can't put it in the group.
sure, definitely.
There are 3 articles are there which are very good, which can use the fundamental concepts.
Up to what level of LH on day 2 one can start IVF stimulation is the question.
Which one?
Ma'am, while you're asking these questions, can I launch the poll so they can answer it side by side?
Yes. Sir, up to what level of day 2 LH one can start stimulation is the question from a delegate.
If your day to LH is risen, are you looking at a low responder? Because what happens is, if your day to FSH is more than 50, what is your FSH levels and AMH levels? Because before AMH has come in, the criteria that were used on day 2 was FSH LH or FSH and E2 to identify decreased ovarian reserves. So if your day to FSH is more than 50, what is your AMH or FSH level? If they are low, then is your report right? Or is there a cyst development in the ovary? That's how I would look at it. Because if you look at the speed of 2 editions back, there it was written a day to FSH of more than 50 can be considered as decreased ovarian reserves. So that is how I would look at it, because it's abnormal to have more than 50. The second thing is, if it is more than 50, if you put a probe, what is the endometrium looking like? It should not look flat. Or in the ovary should show some follicles. Or she is extremely poor responder with increased adipose tissue, where adipose is an endocrine gland, And in that patient, your day 4 E2 levels will be less than your day 0 values. Once the ovary starts producing the estrogens, the adipose production of estrogen decreases. Suppose you have a day 2 levels in a poor responder patient, and you have 4 follicles. Your day 2 level is 70. You start stimulating. Your day 4 level gets 50. Don't get worried. Look at the ovary. Is the follicle growing? Because there, the endogenous production by the adipose tissue is suppressed, and the ovary is producing it, and your E2 levels will rise from the 50 level onwards. Most of the time, we blame the lab report as wrong lab report. We never think adipose as an endocrine gland.
So, in this vein, I have two questions. One is, when do you really recommend testing for LSTGR or receptor polymorphism? What are the indications as clinicians we should really think of to tailor our stimulation protocol? One. The second thing is whether across responders to be on a safer side using HMG for all from the beginning of the cycle rather than encountering problems.
Repeat the second question again.
Whether we can just add an HMG to all responders, whether it's normal responders, poor responders, or hyper responders, and then we are not into any trouble at all, rather than getting into trouble on day 5, day 6 with a hyper response. Why not give HMG to all patients from the beginning?
My answers will be as follows. The first and foremost is, if you are using pharmacodynamics, use it for everybody. Otherwise, don't use it. Because then only you get the feel of the receptors and its effect on the drugs. If you do not want to use for every patient, then read the LH supplementation articles of the PCO Wong, which I showed. It gives you a lot of clarity when to give LH supplementation. Then you don't have to do the LH receptor. Because if you're using selectively, you will never get a feel of the molecule, and you'll never understand the interactions of the molecule, because your mind is not tuned to receive that information, because you're doing on and off. And then when you read the literature is confusing because different people are giving different responses. So the first thing is, if you want to use receptors on a daily basis. Receptors are not meant for poor responders. And second thing is, if you feel the follicle to oocyte output ratio is abnormal, there's a small place for receptors in the second cycle, but not for poor responders. And if you want to practice receptors, do it on an everyday basis or no. Practicing receptor polymorphism and practicing LH supplementation are two different concepts. You can separate receptors and do LH supplementation by the concept of ongoing hyperresponder. In an ongoing hyperresponder, you have adequate number of follicles, but you have given adequate dose of FSH, but still they're not growing. That means they need LH, and the LH need not be above 75. The upper limit is 75. Once you identify it on the 6th day, don't increase the FSH, but add 75 units of LH. Your cycle is rescued and you get good outcomes. Equally normal, there's no difference in the outcomes in the ongoing hyperresponders. LH supplementation and LH polymorphisms are not designed for poor responders. That's a statement one should remember. But actually, in reality, people are giving it only for those two people.
So what about advanced maternal age? Like, you were mentioning that as age advances, the receptor status is also going to vary. So any which way in advanced maternal age, we want to add an LS activity at the beginning. So,
In advanced ovarian responses, there I divide them into three groups. Poor responder, normal responder, and hyper responder. If I'm going to select a polymorphism, there I'm going to do it in the hyper responder and the normal responder. When I say advanced age, I'm saying more than 37 years in relation to stimulation protocol. Second thing is, I also explain to the women the advanced maternal age factor in a different way. I tell them distance to menopause. By saying that, I'm not hurting them. Because for them, if you say your age factor is there, it's puzzling for them because they're young. But when you say the word distance to menopause, then they get clarity. Ask how many of them understood the word advanced age, and also say the distance to menopause. As the distance to menopause decreases, the quality of oocyte becomes poorer. Their appreciation of that is extraordinary. Because in a normal life, there's nothing called age factor unless somebody is old. What, Sindhuja? Yeah, you're smiling.
Yes, everything you say is like a punch dialogue, sir. So it's nice to. I'm having a fan moment, sir. I'm just listening to you.
Because that's the truth, no?
Absolutely, sir.
Distance to menopause is a more appropriate statement.
Yes, sir. No, I think that's a besides so many other take-home messages, the way we communicate and this particular line is also very important because that's what patients don't want to hear, especially when they're getting married at a certain age these days. And
Yes.
they get annoyed because that's the first thing that every clinician, every doctor says to them, saying that you're already old.
But saying distance to menopause, that's more appropriate statement.
Yes, sir.
it gives a positive feeling for the patient to begin anything. So that's a nice point for all of us to communicate with the patient. One delegate has asked that giving FSH and HMG starting from day 2 in a normal responder reduces the number of follicles that recruited.
I stopped using HMG almost 10 years back. The rationale was the Japanese group have found pyrons in the HMG molecule.
What in HMG molecule?
In the HMG lyophilized powder, they found pyrons, PIRON. My pronunciation is wrong.
Okay, sir.
Jacob's disease. The second thing is, if you look at the source of urine 20 years back and now, it is different. 20 years back, the urine was sourced from nuns. Now it is sourced from the Argentinian slums and the West Bengal slums. We never realize or never ask where is the source of the urine. And there is also Vatican was a stakeholder in the Serona company, which was earlier manufacturing of HMG. Vatican also has a lot of investments in industries. And that's how the nun's urine has come into play. And after Serrano has dissolved, Vatican has withdrew from this thing. The source of urine became a product. We never look at the behind the scene of the industrial activity. And New Zealand has banned, Australia has banned the use of urinary products. Japan, to a certain extent, has banned the use of urinary products. Till then, they never thought in lifeless powders. This Pyron of my pronunciation is wrong, PIRON, will not be present in lifeless powders. But the Japanese have found out by a modified method they are present. But the species that were present were the safe group. But since they are present, a caution was then. That was when the Australian government and the New Zealand government has stopped using urinary products in their country. The second thing is the HMG preparation in India and Europe, the manufacturing process compared to US is radically different. Are you aware of that? So in USA, the cost of HMG is more than the cost of recombinant FSH. Because the manufacturing process is different. The FDA has approved a different manufacturing process which is much safer than what else the everywhere world uses it.
So in India, the main thing is the cost factor, and what I understand that one cycle, the first cycle should be the best cycle, and to avoid further cost increments, we should use the best of the medication, recombinant thing. But again, HMG is widely used, urinary SSH is widely used, highly purified products are widely used. So in that scenario, I have two questions. One is, starting the cycle with both combination of HMG and SSH, does it have an impact in a normal responder in terms of output, follicular output? The second thing is, can this be a strategy where in the first 5 days we use a recombinant SSH, and then to reduce the cost, we change over from day 6? Will that have an impact on the receptor status?
No, I would prefer to use a single product. Be it you suppose I'm in a different economic situation. The first thing is I'll ask that I will visit the company facilities. Then look for myself what's the manufacturing best practices, and then give brand loyalty to that company. Then their cost of marketing comes down. Then insist on the cold chain management much more stringently. And also give me a single batch and inform me every time the batch is changed. First of all, I've been to a couple of manufacturing units in India. There were surprises and also appreciation also of those units. And there's nothing wrong, but they will allow you only if you give brand loyalty. I didn't hear you properly.
No, sir. We are hearing you. You were telling us about brand loyalty and
yes. What happens is you never look at it. The representatives come from headquarters to you to meet you. What's the cost of the manpower? And he's paid an X amount of money. And every month he comes to see you, even though there are no new products. If you give brand loyalty, all those are eliminated, no, that costing. You can see and go and see and acquire other customers. If he's not sure about your next month business, then every month he'll come and see you. Then why will he allow you to see his company facilities, everything? If you do not if you give brand loyalty, you get better quality information and you get access to the background information. And if you don't like, then you can change it. But in the next one also, make up your mind that you're going to give brand loyalty. If you give brand loyalty, suppose you're going to buy fruits, the person who is going to sell the vegetables is going to give a better selection if you go every day. That we see it in the everyday, no?
Understand, sir. So now, like in this way, I would just want to know some practical points. For example, if there is some person who is coming and telling us about highly purified HMG, it is going to give us, this is the thing. What questions you want us as clinicians to ask them? What is the process? What is the bioassay? How much is the purification step? What certification we are supposed to be? Because most of us will not really have the access to go and visit the manufacturing unit. So what questions we really have to put in to those people so that we are sure that we get the good quality product?
Are they being exported? Are the products being exported? If they're being exported, are they being exported to the European continent, the North America, or the South America? The certifications are different. In the most stringent is North America. In North America, they look at the source of the product also. Because what happened is 15 to 20 years back, when heparin was used, which is extracted from pig intestine, whole source was for the world was from China. Then in between, the distributors, everything were different, but the end manufacturers were only two companies in the world, which were based in Europe. The product was coming from China, and the problem they had was somebody in China mixed quantum sulfate to this. That is the bone. The coagulation times have been prolonged, and these patients ended up with renal failure and cirrhosis. From that time, FDA has started looking at the source product also. So the problem is, another problem is, our reproductive fertility division is under transformation. You'll feel dogfighting because they are not corporate IVFs, they're venture-funded IVFs. We confuse between a corporate IVF and a venture-fund IVF. In venture-funded IVF, it's all about valuation. It's all about numbers. And the owner changes every 5 years, 5 to 6 years. When the investor moves away after 5 to 6 years, the pressure is numbers and the potential future valuation rather than the quality of management. The second thing is we are literally hunting down the patients by calling them once they come to the clinic again and again. That behavior is not there in other medical units. And second thing is, infertility and reproductive medicine has boiled down only to IVF. The whole gamut of reproductive medicine is shifted to intervention-related assisted reproduction and nothing else. So when you look at scientific publications, all of them are centered around that. And in 2011, both oncology and infertility were at the same point. Now oncology has everything is driven by genomics. And all cancers have been identified about a particular gene in which is associated with, but not reproductive medicine. Reproductive medicines have splintered into small units. Oncology has aggregated into large units, with chemotherapy units being segregated to outside. Here, if you really look at it, some of the assisted reproductive units are, with due respects and apologies to everybody, are becoming cheaper than in McDonald's stores. And that will have its own impact. We are assuming the government is sleeping. This ART bill is a draconian law. And yeah, all of the people are thinking government is not coming and inspecting, but your own colleagues will be the whistleblowers in another 2 to 3 years. Somebody will be thrown out unjustly. He'll be an aggrieved person and he knows everything about the unit. He'll become the whistleblower. Don't be surprised in 2 years to see a lot of them, because the HR department of the corporate are very aggressive, non-polite, and behave as demigods. So the moment they hit somebody unjustly, he's going to revolt and become a whistleblower. People are expecting the government to inspect. I'm not expecting the government to inspect. I'm expecting the whistleblowers to blow up the things.
So when we choose these gonadotropins, we ask about whether they're exporting and where are they exporting and what is the source of raw materials and what are the things that we should do.
Most of the time, the field representative does not know. The general manager might know, but the national manager knows it. So when you're choosing a product, ask for the visit of the national manager. The field manager, the field representative, the state manager, 90% of the time they do not know. They're not given that access because they keep on changing. And poaching between companies is very high. So you get that quality information only from the national sales manager or the head of the medical team. Even it take time, ask for their visit. And don't put it on email.
Sindhu, you can just share the poll question. Sir, what is your take on biosimilars emphasis, sir?
They're equally good. Only thing is, maybe per unit efficacy might be different. What it needs 75 might need 85 units. But in terms of function, the answer is they're equally good, provided you use them consistently. Don't mix and match.
Sindhu, can you just take the
Sir,
poll?
yes. Sir, I'm just publishing the results of the polls. So the first question was, which of the following best describes the function of LHCGR and FSHR genes in reproduction? Majority have answered it correctly, which is they encode receptors that mediate the action of LH and FSH on the gonads. The next question was, how can polymorphisms in the FSHR gene affect the IVF outcomes? Almost 88% have answered correctly, which is they can influence the ovarian response, thereby affecting the required dose of recombinant HFSH. The next question is, a woman with AA genotype of the FSHR polymorphism is most likely to experience which of the following during ovarian stimulation? Lot of mixed responses for this, but majority have answered correctly, which is a higher dose requirement of recombinant HFSH to achieve optimal stimulation.
I would like to add one more caveat to that.
Yes, sir.
Their age of the woman also makes a difference.
Okay.
A 25 years woman and a 30 years woman, we found a different response. That's the only caveat I want to add.
Okay. The next question was, what has been observed in women carrying the GA genotype of the LHCGR polymorphism RS2293275 in relation to ovarian reserve? This was there in sir's presentation. So the correct answer is they display a slightly lower AFC compared to GG or AA genotypes, which is 59% have answered it correctly. Mixed responses for the other options. And the last question was, why is it important to consider genetic polymorphisms in the context of IVF treatment planning? Majority have answered it correctly, to personalize stimulation protocols for optimal ovarian response. So, sir, this shows that everybody has paid attention and got most of the take-home points correctly.
This is an evolving area. What I told today might change in 5 years. That's my humble submission.
Absolutely, sir. But we should know what is happening now to understand whatever you're going to update us after 5 years.
And the second thing is in the next thing, Kavita and Kavita Lakshmi's PhDs are on, one was PhD was on 29, one's PhD is on 680. Then we found a difference in PCO and non-PCO groups, and also in comorbidities. So that's the reason I deliberately segregated this lecture. The carry home message here is hyper responder is a concept which is radically different from poor responder. LH supplementation and polymorphism. LH supplementation is not for a poor responder, is for optimal follicular oocyte output ratio. Third is, if you want to use polymorphism and if you want to personalize your stimulation protocol, do it for everybody, but not selectively, because you will have to get a feel of the whole problem. The second thing is, if somebody is introducing a polymorphism into their own clinic, then I expect them to do their own scans. Then only they see that response. Otherwise, that 9, 8, 10 will not make a difference. Okay then.
Thank you, sir. Thank you so much for your time, sir.
I think we'll have the part 2 session where you will be delving more about receptor polymorphism across the responders.
Yes.
Also, we can get to know how to interpret these reports, whether it's homozygous, heterozygous, what is AA, what is GG. I think we can have some more.
The next lecture I'll divide it into two things. The first half an hour is between FSHR 29 for 15 minutes, 680 for 15 minutes. The next 30 minutes is putting a series of slides of the genomic pattern. What we realized is when we combined everything, there's 64 data sets. Three FSHR receptors, 9 subtypes, each one having 3. Then LHCGR another 3. then 6 page per insertion, another 3. They became 64 data sets. So, and we'll be telling you what to avoid, what to look at. So that way what happens is interpretation of the report becomes easy.
Okay.
Because what I find is the information is coming in, but we are not able to interpret the report. Then I feel we are losing an opportunity. So that's the reason now I have made it clear that LH polymorphism is needed, or you can do it without it on an ongoing hyperresponder. But I also said that all these apply when you give only FSH, not HMG. When it comes to FSHR, we should add the LH receptor to that data and then interpret it.
Okay, sir.
They should not be interpreted in isolation. So in the next lecture, the first 15 minutes will be about FSHR 29. This next 15 minutes is 680. Then a combination of the LHCR with these 3 things, how to interpret it. That makes things simpler.
Okay. Thank you so much, sir. We are extremely honored and humbled. You've been talking for the last 1 hour plus for all of us. And thank you all the delegates for joining us on this weekday evening. Really appreciate the time and effort. Thank you so much, sir.
And I appreciate what you and Sindhuja are doing. Congratulations.
Thank you, sir. I just want to say one thing, sir. The ma'am and I talk about you almost every day. And every day we remind ourselves in a world where we can be anyone, let's try to be like Raju, sir. That's something that we keep saying. This is not to flatter you. This is really to say that we take you as an inspiration in so many things that we do, sir. You may be in VIZAG, but we think about you in Chennai every single day. I'm sure many others also do.
Thank you very much.
Thank you, sir. Good night, sir.
Good night.
All the delegates, please, sharing this to all of you. And also, if you have further questions on this particular topic, you can share it so that we can ask Raju sir to answer it. And we'll also be sharing the relevant articles, and also whatever sir has mentioned, we will share those articles and share it with all of you along with your e-certificate. Thank you so much, all delegates, for spending your evening together with us. Thank you.
Thank you, ma'am.